While treating periodontal disease, wherein you have plaque and calculus, an associated pocket formation and a reduced amount of bone level, in few of the patients, just doing your regular scaling and root planing and sufficing with them antibiotics may not help to control the disease part of it. So in such patients, you might require certain additional chemotherapeutic agents which are there in order to make the gingiva healthy and get back the healthy gingiva as well as try to achieve the bone level as well. So one such chemotherapeutic agent is something called as host modulation and therapy. So first we're going to talk about what exactly is host modulation, and then we'll talk about what is exactly the host modulation therapy. So herein we're going to cover up two chapters according to the 10th edition Karanza. So as I mentioned, we're going to talk about first in detail regarding what exactly is host modulation and what exactly is host modulation therapy, the different used agents in host modulation therapy. First, we'll look into some definitions, wherein host is an organism from which a parasite obtains its nourishment, or in the transplantation of tissue, the individual who receives the graft is what we term as host. So modulation is the alteration of function or status of something in response to a stimulus or an altered chemical or physical environment. So always remember that host modulation therapy is a chemotherapeutic approach in order to treat periodontal disease. Before we get into what exactly is host modulation and host modulation therapy, ask yourself a question. Many individuals harbor the putative pathogens associated with periodontal disease, but not all of them develop disease. Like in most of us may be having gram-negative bacteria, but not all of us develop periodontal disease. But why is that so? That is because mainly it has got something called as the host response. So apart from the bacterial part, which plays a very important role in the development or pathogenesis of periodontal disease, you have something called as the host response. So in the next slide, I'm going to show you a pictorial picture. Please do understand that very well, and only then you can probably understand the class even better. This is what is the pictorial response or a pictorial representation of what exactly happens when you have a microbial challenge and how exactly the host response become responsible for your pathogenesis of periodontal disease. This part of it I'll be dealing in very much detail when I'll be talking about immunity and inflammation. So first, you can see that there is something termed as microbial challenge. That is, you have your gram-negative bacteria which get accumulated within the plaque. Because of that, there's going to be some antigens which are presented, and there will be lipopolysaccharides which are again an important coating or around the gram-negative bacteria, and various other virulence factors which are there by your periodontal pathogens which are mainly gram-negative bacteria. So once you have a microbial challenge, you have antigens, you have LPS, that is your lipopolysaccharides, and a whole lot of virulence factors, you have the host immunoinflammatory response which is initiated. So how exactly that happen? Initially the PMNs will come. Even then when they cannot control, the antibodies will come in action. I hope you guys can relate it to what you have dealt with this in your pathology, wherein you studied how exactly the neutrophils come in, how the antibodies act. So once these cells, that is all your neutrophils, monocytes, macrophages, and all sorts of inflammatory cells come into action, they release something called as cytokines and prostaglandins. Okay, cytokines, just remember now, they are messengers to communicate between individual cells. Okay, so only once an cytokine attaches to a particular cell, you have the activation or deactivation of a particular type of inflammatory cell. So there are a whole lot of cytokines. Cytokines again are both protective as well as destructive. So what happens is when you have cytokines, it of course controls the disease. It is very essential to control the disease. At the same time, cytokines do have some amount of destructive action as well. And most amount is the matrix metalloproteinase enzyme. I hope you guys can remember MMPs are very important and are a part of collagenase enzyme Collagenases means which destroy collagen fibers. So now you can imagine destructive means that is the reason when you have a whole lot of cytokines and prostaglandins and the MMPs which are released, you have the connective tissue and the bone metabolism which is affected. That is, you will have loss of collagen fibers, you will have the bone destruction to happen, and once this happens, you have the clinical signs of disease initiation and progression. So always remember that because of this host response, not all patients having gingivitis get converted into periodontitis, and not all patients having gram-negative bacteria do develop gingivitis or periodontitis. Only there are certain patients who are disease resistant and there are certain patients who are disease susceptible. So because of this, host response which is there, you have the host modulating agents or the host modulation which can occur mainly at three targets. So first, MMPs, that is when MMPs are present in excess. Okay, you do remember that MMPs are normally present as well because normally there is a turnover rate of collagen as well. So that is very essential to degrade the diseased or the aged collagen fibers which are there. Only when the MMPs become in excess, they start destroying even the normal tissues which are to be present. So the first target of our host modulation will always be the MMPs or the matrix metalloproteinases. The second, that is, you try to inactivate them or stop the action of MMPs. The second part of it are your cytokines and the prostaglandins, that is, you inhibit the action of cytokines. And the third part of it will be your osteoclast. What is the main function of osteoclast? It causes bone resorption. So you want to stop the action of osteoclast to prevent bone resorption. So now we know with the host response how exactly it acts, and you know the three primary targets which are your MMPs, the cytokines and prostaglandins, and the osteoclasts which are present in the disease process. Apart from the three primary targets, what we saw, that is our MMPs, the cytokines and the prostaglandins, the osteoclasts, you have the fourth target, which is you want to shift the periodontal balance towards a healthier side. So whenever you have a disease process set in, you have the various risk factors, genetics, smoking, diabetes, overproduction of pro-inflammatory or the destructive mediators and enzymes, which are mainly the interleukin 1, 6, prostaglandin E2, TNF-alpha, and various MMPs, underactivity or overactivity of aspects of the host response, poor compliance for the patient, poor plaque control, and of course a whole lot of subgingival bioburden which is there. So if you need to shift the periodontal balance from the disease side towards the healthier side, of course can reduce the risk factors. That is, you can educate the patient to stop smoking and maybe educate the patient to get his or her sugar level under control. But genetics is one thing which we cannot really control. So you just ask them to reduce the amount of risk factors. Expression of host anti-inflammatory or protective mediators. That is, you give some protective mediators against the cytokines. That is, you want to stop the action of cytokines by giving some anti-inflammatory or protective mediators, mainly your interleukin 4, interleukin 10, interleukin 1 receptor RA, and tissue inhibitors of matrix metalloproteinases, which are otherwise termed as TIMS. And of course, you add on host modulation therapy, you have resolution of inflammation. You have the oral hygiene instructions in order to compensate for the poor compliance of the patient. You have to reinforce scaling and root planing, flap surgeries, antiseptics, antibiotics as well to reduce the health challenge, bacterial challenge. So once you have all these things achieved, you will always shift the balance from a disease side towards a healthier side. So now we know what exactly are the host response, why exactly it is important, and what are the four targets of host modulation therapy. So with this background, now let us see what exactly is host modulation therapy and what are the various agents present in them. Host modulation therapy is an intervention in periodontal therapy, and always remember it's an adjunctive to your mainstream periodontal treatment. That is, you have to do your scaling, root planing, and flap surgeries as indicated, and host modulation therapy acts as an adjunctive to your mainstream periodontal treatment. By definition, please split the definition into four parts. It becomes quite easy to remember and understand as well. So it is a treatment concept that aims to reduce tissue destruction. So we are trying to stop the tissue destruction and stabilize or even regenerate the periodontium. That is, you want to stabilize the periodontium in an healthy state, and even you're trying to get back the lost bone and the lost tissues and the lost cementum as well. How do you do it? By modifying or down regulating the destructive aspects of the host response. That is, you want to get down all the destructive enzymes or all the destructive cytokines which are present due to the periodontal disease, and upregulating protective or regenerative responses. That is, you want to increase the amount of anti-inflammatory part or the regenerative responses which are there. So now, by definition, it is a treatment concept that aims to reduce tissue destruction and stabilize or even regenerate the periodontium by modifying or down-regulating destructive aspects of the host response and upregulating protective or regenerative responses. So this definition is very important. Split it up, as I've told you, into four divisions, and it becomes quite easy to understand and remember as well. And definitions have to be how it is given in the textbook. What exactly is the rationale behind host modulation treatment? Whenever you do a periodontal therapy, that is with your scaling, root planing, your oral hygiene instructions, your flap surgeries, you're just reducing the bacterial challenge. That is, you're removing all the local factors which have accumulated over there, due to which the outcomes are not very stable all the time, because the host is not modified completely, because you are not targeting any cytokines. Just by reducing the bacterial challenge and the inflammatory process, you are achieving some stable outcomes, but they are not long-term outcomes. And you need to have something to shift the periodontal balance towards a healthier side. How do you do it? By reducing the persisting bacterial burden and the pro-inflammatory destructive events in the tissues. Thereby, you resolve the inflammation and downregulation of the destructive processes. So this is mainly achieved by your host modulation therapy. By removal of plaque by SRP or flap surgeries, it just reduces the bacterial load but does not completely eliminate. Recolonization can easily occur because you have the bacteria, certain bacteria which has got the property of penetrating deep into the epithelium and into the connective tissue, like Porphyromonas gingivalis and Fusobacterium nucleatum. So even though you do a good amount of scaling and root planing, we are not very sure. Even you do a flap surgery, we are not sure you have eliminated the whole amount of bacteria. So in order to target these things, host modulation is very essential, wherein you have the potential to downregulate the destructive aspects and upregulate the protective aspects of the host response. So with the combination of the conventional treatment, that is your mainstream periodontal treatment, that can be SRTC or a flap surgery, with host modulation therapy, you will have reduction of the bacterial load and maintain the periodontal balance towards a healthier side, and hence the healing response will be initiated. So I hope you guys have understood what exactly is the rationale of host modulation therapy. Just to summarize, you by doing a normal scaling, root planing, or a flap surgery, you're just reducing the bacterial load. You're not targeting the host over there. So with the addition of the host, you're completely reducing the bacterial load with your conventional treatment, and by host modulation, you can reduce all the inflammatory responses, pro-inflammatory responses, the cytokines, the prostaglandins, everything are addressed with your host modulation therapy, wherein you definitely will achieve a shift towards the healthier side. That is, the periodontal balance will always shift towards a healthier part of it. So the host modulation always treats the host side of the host bacterial interaction. But one thing we need to always remember is host modulation therapy will not switch off the normal defense mechanism or the inflammation. That is, what exactly is required to protect us from having a disease or having periodontal disease will not be switched off by our host modulation therapy. They just address the excessive or pathologically elevated inflammatory process, enhancing opportunities for healing and periodontal stability. So you need to always remember these things. Voice modulation therapy is always an adjunct to your mainstream periodontal treatment. You can never use it as a standalone periodontal treatment. That is, you will have to do your scaling and root cleaning, you will have to do your flap surgeries, only then add on the host modulation therapy. And the second part you need to always remember is that host modulation never switches off the normal defense mechanism or the inflammation. They ameliorate excessive or the pathologically elevated inflammatory process only, thereby achieving or shifting the balance, periodontal balance towards a more healthier side. Now, having known what exactly is host modulation, what exactly is host modulation therapy, what is the rationale behind it, now let us go into host modulating agents. So there are some locally or systemically administered drugs. In the systemically administered drugs, you have NSAIDs, bisphosphonates, and STD. In the locally administered, you have the NSAIDs, the enamel matrix proteins, the growth factors, and the bone morphogenic proteins. All of you know that how exactly NSAIDs act. That is, they mainly address the PGE2. They inhibit the prostaglandins. So why exactly is prostaglandin so important in periodontal disease? Prostaglandins are released by neutrophils, macrophages, fibroblasts, and gingival epithelial cells as a response to LPS. LPS is lipopolysaccharides. So prostaglandins always upregulate the bone resorption by osteoclast, inhibit fibroblast function, inhibitory and modulatory effects on the immune response. So NSAIDs mainly inhibits the formation of prostaglandins and thereby reduces the tissue inflammation. Various NSAIDs used were the indomethacin, flubrofen, naproxen as a systemic and ketorolac mouth rinses locally. But the greatest disadvantage was patients having GI problems, hemorrhage, renal, hepatic impairment as well. And the greatest disadvantage of using NSAIDs as a host modulation therapy was something called as rebound effect. That is, you put the patient on a normally host modulation is put in for a long term. That is, you put the patient on 3 to 6 months of host modulation therapy. So until that time, the periodontal disease is controlled. But when you stop the um, treatment, that is host modulation therapy, periodontal disease either exaggerates or comes back in a much severe form. So that is what we term as a rebound effect. That is, once you stop the NSAIDs use as a host modulating agent, there is going to be a reversal of your periodontal disease in a much worse way, and hence no longer NSAIDs are indicated as a host modulation therapy. But when a question comes on host modulating agents, you do have to mention local and systemic NSAIDs, and you can mention at the end that they are not indicated, no longer indicated for a host modulation therapy because of these issues as mentioned above. The next agents which were used were the bisphosphonate. Does it strike somewhere where exactly it was used? It was mainly used in the treatment of osteoporosis because bisphosphonates were said to inhibit bone resorption by disrupting osteoclast activity and had got some amount of anticollagenase activity as well. But the greatest disadvantages of giving a long-term bisphosphonate therapy as a host modulating agent was it inhibited bone calcification, induced changes in the WBCs, and leads to avascular necrosis as well. Okay, and the various agents used were your epidronate, alendronate, and pamidronate. And because of these disadvantages of inhibiting bone calcification, inducing changes in the WBCs, and avascular necrosis, bisphosphonates have no longer been approved as a host modulating agent. Again, mentioning like NSAIDs, if a question comes, you need to mention all the agents, but if it is no longer recommended, just write the disadvantages, and this is the reason it's no longer recommended as host modulating agent. The next important agents were your enamel matrix protein, growth factors, and bone morphogenic proteins. This will be dealt very much in detail when class has been taken on regeneration. Right now, remember that BMP2 and sub-1 have been used, and the other one would be your platelet-derived growth factor and the insulin growth factor. And Emdogain is one FDA approved host modulation therapy which is locally administered. So Emdogain is the only FDA approved locally delivered host modulation therapy. what exactly is endogane, how is it used, how do we, what is the action, everything will be dealt when you're talking about regeneration. So right now remember, endogane is a part of FDA approved locally administered host modulation therapy. The next important agent or the most important host modulating agent is what is sub-antimicrobial dose doxycycline, or which is otherwise termed as SDD. Please do remember this. STD is sub-antimicrobial dose doxycycline. Do not mention it as sub-dose doxycycline, low-dose doxycycline. No, it is always sub-antimicrobial dose doxycycline. So it is the only FDA approved, systemically approved host modulation therapy. Treatment of periodontitis, use an adjunct as mentioned above, never used as an monotherapy. As I rightly mentioned previously, it's always that host modulating agents have to be used as an adjunct to your mainstream periodontal treatment, and they can never be used as a standalone periodontal treatment at all. And the trade name of the sub-antimicrobial dose doxycycline is Periostat, which is given in a dose of 20 milligrams for a period of 3 to 9 months and twice daily. Of course, this is not commercially available in India as yet, but this is what has been given: Periostat 20 milligram dose, 3 to 9 months duration, twice daily, without any of the side effects. We'll see that in the next slides. So normally when you give doxycycline, you give a loading dose of initial 100 and 100 milligrams BD, okay, on the first day, and followed by 100 milligrams for maybe 7 days up to 14 days. But imagine giving an antibiotic for 3 to 6 months. What would happen? It would definitely lead to a lot of antibiotic resistance. So to avoid antibiotic resistance, STD preparation was introduced containing 20 milligrams of doxycycline by Golub in 1990, as opposed to 50 or 100 milligram dose that is available for antibiotic purposes. Okay, so the mechanism of action. So there is a least chance of developing any antibiotic resistance at all, because that is the reason it is called as sub-antimicrobial. So the antimicrobial action is completely eliminated in this 20 milligram dose of doxycycline. The main mechanism of action of this STD is it inhibits MMPs. That is, even once the MMPs are present, it inhibits the MMPs, so thereby preventing loss of collagen fibers. It inhibits the conversion of latent MMPs to active MMPs. Always remember that MMPs are present in a latent form, that is, in an inactive form. So once there are certain cytokines which come and give a signal to these MMPs, only then they get activated. This we'll be learning very much in detail when we're talking about immunity and inflammation, not to worry about it. Right now remember that MMPs are always present in an inactive form or a latent form, and only when the cytokines give a signal, then they get activated into active MMPs. Okay, so either you can directly inhibit the active MMPs or inhibit the conversion of latent MMPs into active MMPs. So STD has got both the actions, which is great. Then you have down-regulating expression of key inflammatory cytokines. That is, what were the cytokines we read about? Interleukin 1, interleukin 1 alpha, 1 beta, interleukin 6. All those things will be inhibited by your STD. Scavenges and prevents production of ROS. What is ROS? Reactive oxygen species. That is your nascent oxygen, your hypochlorous acid. Those are all byproducts of the metabolism of certain bacteria which are present in the periodontal disease pathogenesis. So this STD not only has got action on MMPs and inflammatory cytokines, but also prevents and scavenges. That is, it reduces the action of all the reactive oxygen species, stimulates fibroblast production. That is, some amount of healing is initiated, reduces osteoclastic activity and bone resorption, and stimulates osteoblast activity and bone formation. If we can now correlate the primary targets, what we spoke about, that is MMPs, the cytokines, the prostaglandins, and osteoclasts, and thereby shifting the periodontal balance towards a healthier side, STD achieves all the 4 targets. So it acts as an excellent host modulating agent. And this is one of the favorite questions in your theory as well. It can come as a main question, it can come as a short essay, and or it can come as a short notes as well. So this is one thing you really need, you cannot afford to leave out when you're preparing for your exams or your theory viva OCs. So based on various studies, what was the clinical significance? That is, what advantage did you find when you give STD as a host modulating agent? When they combined SRP, that is a scaling root planing, with STD, it resulted in mean attachment gain exceeding that of the placebo group. I hope you do know what is a placebo. Increased percentage of sites with threshold changes in probing depth reduction and clinical attachment level gain compared to a placebo. Percentage of sites that underwent resolution were greater when compared to the placebo group. So thereby it achieves a much better healing when compared to a SRP alone or when in comparison to a placebo agent which is given. So STD mainly prevented disease size from worsening, and STD prevented disease progression, which may be particularly important in elderly patients or patients who have refractory form of periodontitis. Who are the candidate patients wherein you can prescribe subantimicrobial dose doxycycline? Patients who are having chronic periodontitis, aggressive forms of periodontitis, smokers who have periodontitis, systemic diseases like diabetes, patients who are having periodontitis, post-periodontal surgery as an adjunct, and of course in cases of refractory periodontitis. Patients who are contraindicated for STD are history of allergy or hypersensitivity to any tetracycline group of drugs, pregnant and lactating women, children under the age of 12 years of age. That is the obvious reason why even tetracyclines are also contraindicated in pregnant and lactating women and children under the age of 12 years of age. And it is always advised to inform female patients that when they are on their STD, it may reduce the effectiveness of oral contraceptives. Now, regarding the safety of SDD, giving up to a long-term duration of 20 milligrams BD for a duration of 3 to 9 months, 20 milligrams twice daily was very well tolerated. Most frequently reported adverse effects were headache, common cold and influenza like symptoms, rash and dyspepsia, and no typical side effects of the tetracycline group of antibiotics were noted. That was, there was no photosensitivity, there was no antibiotic resistance which developed in any of the patients, even though they were given for about 3 to 9 months duration. That to BD 20 milligrams. In the microbial considerations, it does not lead to development of any resistant strains. That is, there are no antibiotic resistance, as I've been mentioning previously. There is no overgrowth or replacement by opportunistic flora. It did not affect the composition or resistance level of either the fecal or the vaginal microflora. So there was absolutely no microbiological worries at all when you prescribe STD for a long-term duration for up to 9 months BD for 20 milligram dose. So STD, I'm stressing again, is quite an important topic. So now we have covered the basics of host modulation therapy. Now let us see what are the recent advances which are present in host modulation agents. So the recent advances are something called as chemically modified tetracyclines. You have your anticytokine therapy, you have lipoxins and resolvin. So these are the recent advances what you have in host modulating therapy or host modulation therapy. So first and foremost would be the anticytokine therapy. Before going into what exactly is anticytokine therapy, remember that cytokines are a category of signaling proteins and glycoproteins used extensively in cellular communication. So now suppose a cell, a particular macrophage or a neutrophil commands a particular MMP. Okay, MMP is also a type of enzyme. So it comes and attach only when the particular cytokine, which is signal from the neutrophil, comes and attaches to any MMPs, it gets activated. So that communication between cellular communication between individual cells is mainly by your cytokines. So anti-cytokine therapy mainly targets pro-inflammatory cytokines like your interleukin-1, interleukin-6 and TNF-alpha. In the types of cytokines, you have chemotactic, pro-inflammatory, anti-inflammatory, growth factors, and immunoregulatory. So you do have pro-inflammatory and anti-inflammatory cytokines. As I've mentioned, your interleukin 10, your interleukin 4 are all anti-inflammatory cytokines. Okay, and in the microbial challenge, when you have cytokine producing cells, that is when you have a microbial challenge, you have the inflammatory cells, which are the cytokine producing cells, leads to activation of a cytokine gene. The release of cytokine happens and the receptors are present on particular cells wherein the cytokine will go and attach to that particular receptor and gives a command for the action of that particular type of cell. So mainly it's between the cellular communication. Cytokines mainly act as a signaling proteins and used extensively in cellular communication. The other form of cytokine classification would be mainly autocrine, that is, they act on the same cell of origin. That is, the cytokines are released from particular cell and it has an action on the same cells. Paracrine, it has got an action on distant cells. Endocrine is they pass through the circulation to a distant site cell which is present. Justacrine are mainly membrane-bound cytokines. Either they act on the same cell or a distant cell. The effect of cytokine are mediated by membrane-bound receptors present on target cells. As I mentioned, now suppose a neutrophil has to come and attach to a macrophage to come and activate it. The cytokines which are released by the neutrophil need to come and attach to the receptors which are present on the macrophages and thereby activate or initiate whatever action is required. So there are various receptors present. I'm just noting a few of them over here. So the receptor for interleukin 18 receptors are interleukin 1 R1 and interleukin 1 R2. For the TNF alpha, the receptor present on various cells are TNF R1 and TNF R2. And for interleukin 6, the receptors present on various inflammatory cells are your interleukin 6 receptor. We'll be able to understand the cytokine part more in detail when I'm going to talk about the immunity and inflammation part of it. So what exactly is anti-cytokine therapy or what are the different mechanisms? So in the anti-cytokine therapy, you have three mechanisms. In the first mechanism, it is mainly cytokine receptor antagonist. That is, you give an antagonist so that it binds to the cytokine receptor present on the target cells. Thereby, it prevents the cytokine from binding to the target cell. So these cytokine receptor antagonists bind to the receptor present on the target cell and prevent the cytokine from binding to the target cell and no activation of the target cell can happen. So one such interleukin-1 receptor antagonist is your interleukin-1 RA. The next type of anti-cytokine therapy is your soluble cytokine receptors which are found in blood and the extracellular fluid. Either there are two mechanisms. One is downregulation. That is, there are various soluble receptors which bind to cytokine in solution and prevent signaling. That is, now suppose the cytokines are endocrine type of cytokines wherein we use circulation to reach the target site. Before it reaches the target cell, you give some soluble receptors which bind to the cytokine, thereby prevent signaling. Okay, signaling. Sorry. The next part of it would be transactivation. That is, these soluble receptor bind to the cytokine and docks to non-responsive cells and activate them. That is, suppose the target cell was a distant macrophage. Instead of attaching to the macrophage, these soluble receptors direct the cytokines to non-responsive cells and activate them. So finally, in the soluble cytokine receptors, you have two varieties wherein the cytokines are bound to these receptors are given which binds the cytokine in the bloodstream and prevent the signaling, or they have transactivation wherein you have the soluble receptors which bind to the cytokine and docks them to non-responsive cells so that there is no activation of the target cell at all. So such receptors examples are for interleukin 18 wherein you give soluble interleukin receptor 1R, and you have for TNF alpha soluble TNF R1 and soluble TNF R2. For interleukin 6 you have soluble interleukin 6R which is present. Apart from the mentioned two, that is cytokine receptor antagonist or your soluble cytokine receptors, which have got a downregulation or a transactivation, you have something called as anti-cytokine antibodies. What do you mean by that? Those agents which act as an antibody towards the cytokine. So they are mainly the anti-cytokine antibodies. So for TNF alpha, you have TNF alpha antibody, and for interleukin 6 you have anti-interleukin 6 antibody. So how exactly did this anti-cytokine therapy come into treatment of periodontal disease? It was mainly used in rheumatoid arthritis, wherein it was used for neutralization of cytokines and blockage of cytokine receptors and activation of anti-inflammatory pathways. Since there is some correlation or some similar pathogenesis mechanisms between rheumatoid arthritis and periodontitis, this was used as a host modulating agent, was introduced as a host modulating agent in the treatment of periodontitis. Commercially available are your infliximab, which is mainly an antibody, that is anti-TNF alpha antibody, etanercept, which is soluble TNF alpha receptor 2, and anakinra, which is mainly a interleukin 1 are antagonists. I've mentioned all the three forms of, or all the three mechanisms examples I have mentioned over here. Of course, the recent trends are recombinant human interleukin 11 and disruption of the various cell signaling pathways. This again, anti-cytokine therapy can come as a short essay, a short notes question, that is for 3 or a 4 mark question depending on which batch you belong to. Having spoken so much about anti-cytokine therapy, of course, it has got some amount of drawbacks as well. That is, the immune system is regulated. That means if you give anti-cytokine therapy systemically, do you think the anti-cytokine therapy is going to act only on the periodontium? Not really. It's going to have an effect on the overall immune system, because of which there are very high chances of opportunistic infection. And suppose the patient is having latent infections, that is some hidden infections, inactive infections which are present before you administer the anti-cytokine therapy. Once you give the anti-cytokine therapy, there is going to be an aggravation or exacerbation of these latent infections, because your whole immune system is going to get regulated, and antimicrobials are very essential in order to prevent these opportunistic infections which could be present. So till now, it's still not being commercially made available, and a lot of efforts have been made in order to overcome these drawbacks which are present with anti-cytokine therapy. So mainly there are three mechanisms. First is the cytokine receptor antagonists which are there. Then you have the soluble cytokine receptors, either which act through downregulation or which act through TANT activation. And finally, the last part would be the anti-cytokine antibodies which are present. The next recent advance would be your chemically modified tetracyclines, which are discovered by Golub. Please do not confuse with STD, that is sub-antimicrobial dose doxycycline, and this is chemically modified tetracyclines. Discovered that the carbon 4 position site was responsible for the antimicrobial activity of tetracyclines. Chemically modified tetracyclines are achieved by removing the dimethyl amino group from the carbon 4 position. The resulting compound did not have antimicrobial activity but possessed the anti-collagenase activity, which is what we require in order to prevent the collagen fiber loss as well as the bone resorption part as well. So right now discovered CMTs, that is chemically modified tetracyclines, range from 1 to 8, and the advantages are rapid absorption, they've got a longer serum half-life, no GI irritation, no antibiotic resistance flora, and can be used safe for a quite prolonged time as well. Please do not get confused between STD and CMT. CMT is chemically modified tetracyclines and STD is sub-antimicrobial dose doxycycline. You may have very similar actions, but do not get confused between both of them. One is tetracycline and one is doxycycline. The mechanism of action of your chemically modified tetracyclines is mainly inhibition of MMPs. Either there is a direct inhibition of active MMPs, or there is inhibition of activation of latent or inactive MMPs, very similar to your STD. Inhibition of pro-inflammatory cytokines, inhibition of nitric oxide synthase, that is, it prevents the formation of your reactive oxygen species, and inhibition of bone resorption. It enhances the attachment of fibroblasts connective tissue to the tooth surface. So here you can see that even your chemically modified tetracyclines have got an action on all the 4 targets what we spoke initially in the class. The non-antimicrobial action leads to reduction of pathological concentration of coagulaginases without affecting the normal collagen turnover. As I mentioned previously, if you can recollect that, I told you that the host modulating agent never reduces the normal defense mechanism. Okay, so here again mentioning that it does not affect the normal collagen turnover, only it affects the disease part of it. So in periodontal disease, mainly we use the CMT3, which has got an action against MMP2, 9 and 14. So CMT3 again has got an action of nitric oxide synthetase, reducing the nitrous oxide, which is nitric oxide, which is an activator of MMPs. So CMTs inhibit the release of inflammatory cytokines like interleukin 6, 8, interleukin 1 beta, TNF-alpha, and TG2. And of course, it is the chemically modified tetracyclines increase the levels of anti-inflammatory cytokines like interleukin 10 and that is main action by CMT3. And CMT3 and CMT8, in addition, one in periodontal disease has got an inhibitory action on bone resorption and promotes bone deposition. It reduces the number of osteoclast and osteoclastic enzymes. And other medical uses of this chemically modified tetracyclines have been as an antifungal agent, inhibition of intimal thickness after arterial injury, diabetes mellitus, and rheumatoid arthritis. But having said that, still no agents are available commercially as a treatment or as a host modulating agent for your periodontal disease. Is still very much in an experimental form. There are certain recent trends which are present. This I've taken from the 13th edition of Carranza, wherein you have resolution after inflammation, that is resolvence. Failure of this resolution, that is once there is a disease process, you have inflammation which comes in, and once the disease process is taken care of, there should be a resolution of the inflammation. If the resolution of inflammation, if the inflammation persists without resolution, it's going to cause a whole lot of tissue destruction. So failure of this resolution is what leads to pathogenesis of periodontal disease and hence introducing resolving molecules. So you introduce some amount of inflammation resolving molecules. That is what we meant by resolvents. In rabbit models, the topical application resolving E1 has shown protection from bone loss, reversal of bone loss, and inflammatory gene expression. The other nutrient supplements which are being used as a host modulating agent or recommended are your fish oil, entry PUFA adjunct to oral hygiene, decreases DCF contents of interleukin 8, interleukin 6 and PGE2. There are something called as pestbins, which are polyenolic zinc binding compounds which inhibit MMPs, and one of the pestbins is present in natural product of turmeric, which has got a similar structure to tetracycline. The anti-inflammatory properties of curcumin, which is a main component of your turmeric, has positive effects on periodontal disease, CVS, that is a cardiovascular diseases, cancer, and your arthritis and diabetes as well. The further part of recent advances are chemically modified curcumins, that is, they have modified the important component present in turmeric, which increases the bioavailability and increased anti-inflammatory action. It can decrease the MMP levels in plasma and gingiva and decreases alveolar bone loss. The next part of it is something called a SAGE, which is semi-synthetic glycosaminoglycans ether. It is shown to decrease inflammatory mediators, decrease impact of AGEs. AGEs is advanced glycation end products among diabetes. If you do not know what are AGEs, kindly open up the chapter on influence of systemic disorders on the periodontium and read what exactly is AGEs. Systemic administration would reduce the inflammatory component by modulating production of cytokines and MMPs. And last is the stem cells, which is used to modulate the neutrophil function and excessive inflammation. So all these things, that is resolvents, your natural supplements of fish oil and the PUFA, and your pestbins, that is a component which is present in turmeric, curcumin, chemically modified curcumin, sage, and stem cells are all the most recent advances in your host modulation therapy. Just to summarize on what exactly is host modulation therapy, we know that there is biofilm which is filled up with a whole lot of gram-negative bacteria. You have the host response which is initiated. You have a whole lot of cytokines, antibodies which come into action and lead to a whole lot of destruction. Whenever you do a host modulating agent, you um, take care of the uh, host part of the response which is present. Of course, can never be used as a standalone therapy, has to be used as an adjunct to your mainstream periodontal treatment. And the rationale is that when you do a scaling root planing or a flap surgery, you reduce the bacterial load. When you add a host modulating agent, you take care of the host response part as well. And always do remember that it can never be used as a monotherapy. That is, you don't do remove calculus, you don't remove the subgingival burden, you just give host modulating agent, it is not going to work out. And one more important thing to remember is it's host modulation therapy never reduces the normal host response, which is essential. It only reduces the excessive or the exaggerated host response which is present. And of course, when you have the host response by a whole lot of systemic agents and a whole lot of local agents which are present, among which Emdogain is the FDA approved locally administered host modulating agents, and STT is the um, FDA approved systemically agent, host modulating agent which is approved. And of course, with the recent advances of anticytokine therapy, chemically modified tetracyclines, resolvins, and a whole lot of things what we just saw in the previous two slides, we have the inflammation which is curtailed and the immune system is modified. Thereby, the periodontal balance is always shifted towards a healthier side. And this is mainly achieved by what is termed as host modulation therapy. This chapter is quite important. You can have the slides and you can take a note of the chemically modified tetracyclines and the anticytokine therapy. It is not available in your 10th edition or even the 3rd edition, Southeast Asia edition, which is there. The recent trends I've taken from 13th edition Karanza. You can take a note of them as well. And this is quite an important topic, can come as a main question, just as define host modulation therapy, describe the rationale behind host modulation therapy, and describe the various agents and individual parts like STD or maybe even anticytokine therapy or chemically modified tetracyclines or recent trends in host modulation therapy can be given as a short essay or a short notes as well. So I hope you enjoyed the class. This is quite an important topic. You'll be able to understand this chapter much better regarding the cytokines and exactly the pictorial diagram. What you please do remember, the pictorial diagram of the host response. It will be very essential when we start talking about immunity and inflammation.